Dear viewers, this is part 3 of the discussion on tobacco-related diseases under the Prescribon Medical Education series. Vascular and inflammatory effects of tobacco smoke on the blood-brain barrier. Tobacco smoke contains over 4,000 chemicals. Over 4 dozens of them are well-established carcinogens. Nicotine contained in tobacco smoke has been shown to negatively affect endothelial tight junctions, cell-to-cell anchoring structures. Increased blood viscosity related to tobacco smoke can lead to impairment of blood flow, risking the integrity of the brain microvasculature, particularly if the interendothelial tight junctions are already compromised. Reactive oxygen species promotes low-density lipoprotein oxidation, which at the vascular level can cause cell injury and the formation of atherosclerotic lesions. At the blood-brain barrier level, reactive oxygen species may induce penocytosis, thus increasing transcytotic movement of substances of cells across the blood-brain barrier. Transcytotic movement across the blood-brain barrier endothelium, but can also cause direct BBB breakdown, especially in conditions like stroke and traumatic brain injury. Reactive oxygen species and nicotine act synergistically with other potentially harmful systemic stimuli, example, hypoperfusion of the brain vessels, to further impair both BBB function and integrity and leads to secondary brain damage. Cigarette smoke contains high concentrations of nitric oxide, which may affect the viability of the blood-brain barrier. Nitric oxide is a critical factor that affects the vascular tone, modulates platelet aggregation, and leukocyte adhesion to the endothelium. Small vessel ischemic disease. Chronic smokers have a higher incidence of small vessel ischemic disease (SVID) than non-smokers. SVID is a pathological condition characterized by leaky brain microvessels and loss of blood-brain barrier integrity. Cerebrovascular injuries. Cigarette smoking increases stroke incidence and brain infarction by approximately 50%, with a risk that rises proportionately with the amount of exposure, whether derived from direct or second-hand smoking. The increased stroke risk caused by smoking has been attributed to both procoagulant and atherogenic effects. Tobacco smoke causes a dose-dependent oxidant-mediated stress responses, cell deaths in vascular endothelial cells, and circulating monocytes, which are the major cellular players in the induction of atherosclerotic lesions. Tobacco smoke exposure has a significant causal relation to the onset of silent cerebral infarction. Silent cerebral infarction is a known cause for progressive brain damage resulting in vascular dementia. Dear viewers, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Behavioral impairment and increased risk of sudden infant death syndrome. The brain serotonin 5-HT system has been demonstrated to play a major role in central nervous system development, cognition, that is memory and learning, and personality and behavioral modulatory processes. In fact, several neuropsychiatric conditions, example, obsessive compulsive disorder, anxiety, depression, schizophrenia, etc., as well as impaired brain functions like sleep disorders, appetite, etc., have been related to an altered serotonin system. Acute inhibition of serotonin neurons which control a wide range of behavioral and physiological processes, is primarily related to an effect on nicotine receptors. Prenatal and early postnatal exposure to tobacco smoke has also been associated with an increased risk for sudden infant death syndrome. New tobacco products, lower risks or more of the same. Besides elevating the risk of at least 9 forms of cancer, smoking is linked to heart disease, emphysema, and pulmonary disorders. Light and low tart cigarettes were introduced with claims of a reduction in harmful components and implied health benefits. Decades later, and after millions of health concerned consumers switched to these products, the evidence demonstrates that these expectations were false. Today, the tobacco industry is introducing a whole new line of products with claims and representations that are stunningly similar to those made for light and low tar products when they were introduced. Cancer and tobacco smoking. How is smoking related to cancer? Smoking can cause cancer and then block your body from fighting it. Poisons in cigarette smoke can weaken the body's immune system, making it harder to kill cancer cells. When this happens, cancer cells keep growing without being stopped. Poisons in tobacco smoke can damage or change a cell's DNA. DNA is the cell's instruction manual that controls a cell's normal growth and function. When DNA is damaged, a cell can begin growing out of control and create a cancer tumor. Doctors have known for years that smoking causes most lung cancers. It is still true today, when nearly 9 out of 10 lung cancers death are caused by smoking cigarettes or second-hand smoke exposure. In fact, people who smoke have a greater risk for lung cancer today than they did in 1964, even though they smoke fewer cigarettes. One reason may be changes in how cigarettes are made and what chemicals they contain. Treatments are getting better, but lung cancer still kills more men and women than any other type of cancer. In the United States, more than 7,300 non-smokers die each year from lung cancer caused by second-hand smoke. Second-hand smoke is the combination of smoke from the burning end of a cigarette and the smoke breathed out by someone smoking. Smoking can cause cancer almost anywhere in your body. Most commonly, blood. Example, acute myeloid leukemia. Bladder, cervix, colon and rectum, esophagus, kidney and renal pelvis, larynx, liver, lungs, trachea and bronchus, mouth and throat, pancreas and stomach. Men with prostate cancer who smoke may be more likely to die from prostate cancer than non-smokers. Smokeless tobacco, such as chewing tobacco, also causes cancer, including cancers of the esophagus, mouth and throat, and pancreas. How can smoking-related cancers be prevented? The most important thing you can do to prevent smoking-related cancer is not to smoke cigarettes or to quit if you do. It is also important to avoid second-hand smoke. Quitting smoking lowers the risk for 12 types of cancer. Cancers of the lung, larynx, oral cavity and pharynx, esophagus, pancreas, bladder, stomach, colon and rectum, liver, cervix, kidney and acute myeloid leukemia, AML, a type of blood cancer. Within 5 to 10 years of quitting, your chance of getting cancer of the mouth, throat or voice box, that is larynx, drops by half. Within 10 years of quitting, your chances of getting cancer of the bladder, esophagus or kidney disease lowers the risk. Within 10 to 15 years after you quit smoking, your risk of lung cancer drops by half. Within 20 years after you quit smoking, your risk of getting cancer of the mouth, throat, voice box, or pancreas drops to close to that of someone who does not smoke. Also, the risk of cancer, cervical cancer, drops by about half. Each puff of each cigarette contains a mixture of thousands of compounds, including more than 60 well established carcinogens. The carcinogens in cigarette smoking belong to multiple chemical classes, including polycyclic aromatic hydrocarbons. They are called PAHs for short. N-nitrosamines, aromatic amines, aldehydes, volatile organic hydrocarbons, and metals. In addition to these well-established carcinogens, others have been less thoroughly investigated. These include alkylated PAHs, oxidants, free radicals, and ethylating agents. Considerable evidence indicates that in human cancers caused by cigarette smoking, PAHs, N-nitrosamines, aromatic amines, and certain volatile organic agents play a major role. Most carcinogens in cigarette smoke require a metabolic activation process, generally catalyzed by cytochrome P450 enzymes, that is P450s, to convert the carcinogens to form substances that can covalently bind to DNA and form DNA adducts. Note: in molecular genetics, a DNA adduct is a segment of DNA bound to a cancer-causing chemical. This process could lead to the development of cancerous cells or carcinogenesis. P450s 1A1 and 1B1, which are inducible by cigarette smoke through interactions with the aryl hydrocarbon receptor, are particularly important in the metabolic activation of PAHs. The inducibility of these P450s may be a critical aspect of cancer susceptibility in smokers. P450s 1A2, 2A6, 2A13, and 2E1 are all also important in the activation of cigarette smoke carcinogens. Competing with the activation process is metabolic detoxification, which excretes carcinogen metabolites in generally harmless forms and is catalyzed, that is promoted, by a variety of enzymes, including glutathione S transferases, GSTs, uridine 5-diphosphate glucuronyl transferases, UGTs, epoxide hydrolases, and sulfatases. The balance between metabolic activation and detoxification of carcinogens varies among persons and likely affects cancer susceptibility. Persons with a higher activation and lower detoxification capacity are at the highest risk for smoking-related cancers. The metabolic activation of carcinogens results in the formation of DNA adducts, which are absolutely central to the carcinogenic process. However, some carcinogens can directly form DNA adducts without metabolic activation. There are ample cellular repair systems that can remove DNA adducts and maintain a normal DNA structure. If repair enzymes are overwhelmed by DNA damage or for other reasons cannot function efficiently, DNA adducts may persist and increase the likelihood of developing somatic mutations, that is, alterations in DNA. Persistent DNA adducts can cause miscoding, that is, insertion of the wrong base, that is chemical, during replication of DNA when DNA polymerase enzymes process the adducts incorrectly. The protective process of programmed cell death, that is apoptosis, programmed cell death, can counterbalance these mutational events by removing cells with DNA damage. The balance between mechanisms leading to apoptosis and those suppressing apoptosis has a major impact on tumor growth. Lung cancer. lung cancer evolves as a result of a series of mutational events. The tobacco-induced pulmonary cellular network presents a unique environment in which carcinogenesis proceeds in complicity with surrounding lung inflammatory, structural, and stromal cells. The pulmonary diseases that are associated with the greatest risk for lung cancer are characterized by abundant and deregulated inflammation. Pulmonary disorders such as COPD are characterized by profound abnormalities in inflammatory pathway. For example, among the cytokines, growth factors, and mediators released in these lung diseases and the developing tumor microenvironment, interleukin IL-1B, prostaglandin PGE2, and transforming growth factor TGF-beta have been found to have deleterious properties that simultaneously pave the way for both epithelial mesenchymal connective tissue transition and destruction of specific host cell mediated immune response against tumor antigens. Note: the lung tumor microenvironment TME includes a variety of tumor reprogrammed stromal cells. A major hallmark of immunosuppression in the TME is the inactivation of cytotoxic CD8 positive T cells. The commonalities in smoking, COPD, and lung cancer begin with the profound alterations induced by cigarette smoke, which contains known carcinogens as well as high levels of reactive oxygen species, ROS. So, dear viewers, this is the end of part 3 of the 3-part series on tobacco-related diseases. For other videos in this series, see Prescribon Medical Education series, Tobacco-related diseases. Thank you for watching this video.